Welcome to the deep dive. Today we're tackling a subject that's, well, incredibly critical and really quite compelling. The assessment and management of severe and multiple injuries.
hmm
Think of this as getting a real handle on what happens in those high-stakes emergency scenarios,
Yeah,
how trauma teams make incredibly fast decisions, and what the priorities really are when time is, absolutely critical.
right.
We've looked into a lot of medical insights for this, the protocols, the thinking behind them. Our mission is basically to pull out the core principles, the key steps, so you can grasp the structured approach to this vital area of medicine.
Exactly. We want to paint a clear picture of how medical professionals navigate these really challenging situations. It's not about turning anyone into a trauma surgeon overnight, obviously,
No, definitely not.
but understanding the systematic approach they use under immense pressure. That's incredibly insightful.
Okay, let's unpack this right from the start. How do we even define trauma in this medical sense? And how is severity determined?
Fundamentally, trauma is physical injury from mechanical energy hitting the body. It falls into two main buckets. Blunt force, think car crashes, falls, or penetrating force, like stabbings or gunshots.
And I gather the type of penetrating trauma can vary a lot geographically.
It really can. It's less frequent in many Western countries compared to, say, major U.S. cities or places like South Africa and, of course, conflict zones. There, sadly, it's much more common.
So what's the key difference in how these injuries present? How does the team approach them differently?
That's a really crucial distinction. Blunt injuries, well, they can be quite deceptive. The energy spreads out, so you can get significant internal damage, maybe multiple injuries that just aren't visible from the outside.
Right, like internal bleeding or organ damage you can't see.
Precisely. Think about a car crash. Massive deceleration forces. The organs inside can be badly damaged without much external sign. Penetrating injuries, though, usually have a clear entry point. Their severity often depends on the path the object took and the energy it carried. But, and this is important, you can't underestimate them. A small entry wound might hide devastating internal damage along that track.
So the team really has to play detective, especially with blunt trauma, to make sure nothing hidden gets missed.
Absolutely. The medical literature really hammers this home. A systematic approach and repeated assessments are non-negotiable. Injuries, particularly blunt internal ones, can evolve. Signs might appear later.
That makes perfect sense. Constant vigilant.
Continuous evaluation is key.
So picture this. A patient arrives, severe injuries. What's the absolute first thing the team does?
Triage. Straight away, it's a rapid sorting process. Who needs life-saving intervention right now?
Priority one.
Exactly. And immediately following that, or even alongside it, is thinking about resources. Does this hospital have what's needed? The specialist, the equipment? If not, a quick decision about transferring to a dedicated trauma center is vital.
And how do they gauge the overall seriousness? Is it just the worst injury or?
It's really a combination. The total body injury severity depends on both the number of injuries and how severe each of those injuries is. It's cumulative.
More injuries, worse injuries, higher risk.
Correct. And in these critical moments, assessment, diagnosis, treatment, they often happen almost simultaneously. There's just no time for the usual step-by-step process. You start treating based on immediate findings.
Time is definitely not on their side. So what are those immediate red flags? The signs showing this is critical.
Several key indicators jump out. One big one is shock. Usually in trauma, it's hypovolemic shock from blood loss.
Right.
But other types are possible too. We need to keep that in mind. Another critical sign is a depressed level of consciousness.
Meaning the patient isn't fully alert.
Exactly. And that could be from a direct brain injury, lack of oxygen reaching the brain, hypoxemia, shock itself affecting brain blood flow, or maybe alcohol or drugs are involved. Often it's a mix.
And that dictates the next steps.
The level of consciousness heavily guides the initial treatment, often regardless of the precise cause initially. And finally, any difficulty breathing is a huge red flag, especially with head, face, neck, or chest injuries.
What kinds of breathing problems?
Fast breathing, struggling to breathe, maybe signs like airway obstruction, laryngeal injury, aspiration inhaling stomach contents, or lung and chest wall damage like a collapsed lung, a pneumothorax, or lung bruising, a contusion.
All demanding immediate attention. So once these flags are up, what are the absolute top priorities?
It boils down to preserving life, using resuscitative techniques to keep the patient going while at the same time finding and fixing the specific problems.
Like stopping the bleeding.
Exactly. Locating and controlling bleeding is paramount. And as we said, it can be hidden. Then preventing brainstem compression or spinal cord damage is critical, especially with head and neck involvement. And of course, diagnosing and treating all the other injuries and complications. It's an ongoing process.
A comprehensive, layered approach. I know there's often a standard protocol, right? A kind of playbook.
Yes, a systematic approach is vital. Programs like ATLS, Advanced Trauma Life Support from the American College of Surgeons, they provide that essential framework. The initial emergency assessment, the primary survey, is foundational.
And that's the ABCs we often hear about, although I think sometimes it's CABC now. What's that about?
You're right. The traditional ABC airway, breathing, circulation is the classic sequence. But in situations with massive, obvious external bleeding, like on the battlefield or sometimes in civilian trauma too, a CABC approach is often used.
Cis 8B.
Catastrophic hemorrhage, life-threatening external bleeding. If you see that, you control that first. Direct pressure, tourniquets, hemostatic agents, before you even worry about the airway.
Wow, okay, so stop the massive bleed, then do the ABCs.
Precisely. If there's no catastrophic external bleed, or once it's controlled, you proceed with the standard sequence. A, B, C, and then D and D.
Okay, let's break that down. What's checked at each step, starting with C if needed, then A?
So C, as we said, is rapid control of that massive external bleeding. Then A, airway. Are they breathing noisily, gurgling, stridor, or is it eerily silent, suggesting complete blockage?
Paradoxical chest movements, too.
Yes, that's another sign. Also respiratory distress. And checking if they can protect their own airway, the gag reflex, if consciousness is reduced. Management means clearing the airway while always protecting the cervical spine. Neck injury is a high risk.
Got it. Then B?
B, breathing. Are they breathing too fast? Tachypnoea. Is the pattern weird? Shallow. Are they cyanotic blue lips or skin from low oxygen? Confused. That could be lack of oxygen too.
And C, circulation.
C, circulation. Signs of shock. Cold, clammy skin. Delayed capillary refill. Press the nail bed. Does the pinkness return slowly? Is the pulse rapid and weak? Is blood pressure low?
D is disability.
Neurological.
Quick neurocheck. Pupil size, reaction to light, and the Glasgow Coma Scale, the GCS. It's a standard way to score eye-opening verbal response, motor response to gauge consciousness level.
What causes decreased consciousness here? Could be poor brain perfusion from shock, direct brain injury, or substances like alcohol or drugs.
And finally, E.
E, exposure. You need to fully undress the patient to examine them completely, find all injuries, but crucially prevent heat loss, hypothermia, and maintain dignity. Warm blankets. Expose only what's necessary at the time.
That's an incredible amount to assess and manage in what must feel like seconds. What interventions are started alongside this primary survey?
Several things happen almost immediately. High flow oxygen for pretty much everyone.
Via mask.
Usually, yes. Ventilatory support is often needed too because breathing is compromised. That might mean assisting breathing manually or even intubation, putting in a breathing tube and using a ventilator.
Especially if the patient is agitated.
Exactly. If they're restless, uncooperative, rapid sequence induction, basically anesthetizing and intubating quickly might be needed to secure the airway and allow resuscitation. At the same time, blood is drawn.
For tests?
Loads of tests. Hematology, biochemistry baseline. Interestingly, blood alcohol level is often checked too. It has clinical, epidemiological, preventative, even legal implications.
Right.
And crucially, urgent blood cross-matching is started. You don't know how much blood they'll need, so they prepare several units typically. Hospitals have protocols for immediate transfusion in unstable patients.
Fluids too, I imagine.
Definitely. Fluid resuscitation starts right away. We'll get into the details, but it means getting large IV lines in arms, maybe neck or groin veins, or if IV access is tough initially, intraosseous access into the bone marrow.
And pain relief. Seems easy to forget in the chaos.
It can be, but it's important. Analgesia, usually titrated IV opioids, not intramuscular or subcutaneous injections if they're in shock, because absorption is unreliable.
Okay, so the primary survey handles immediate life threats, but the assessment isn't done then, is it?
Not even close. That's just step one. After that comes the secondary survey, a much more detailed head-to-toe clinical evaluation. The sources really stress the risk of missed injuries. One big, obvious injury can distract you.
So you need to look everywhere.
Systematically, head to toe, front and back. Paying close attention to all external signs, cuts, bruises, scrapes, sometimes even a tertiary survey later, just to be absolutely sure nothing was missed.
Let's walk through that systematic exam. Head first, what are the key checks?
Neurological status is key. Checking GCS again, pupils, Looking for any CSF cerebrospinal fluid or blood leaking from ears or nose that suggests a skull fracture, and feeling the scalp carefully for wounds or fractures.
And the face?
Priority is making sure there's no bleeding into the airway. Also, gently checking facial bones and jaws for instability. Any abnormal movement or grating sounds crepitus, indicating fractures.
Moving down to the spine, always a big concern, right?
Huge concern.
Uh-huh.
Assume a cervical spine neck fracture in anyone with depressed consciousness after trauma until proven otherwise. Always.
What signs suggest a spinal cord injury, specifically?
Things like warm, dilated peripheries below the injury level due to lost nerve control of blood vessels, breathing mainly with the diaphragm, paralysis or weakness, priapism in males, loss of anal tone checked via rectal exam, and carefully inspecting and feeling the whole spine for tenderness or deformity.
And the chest. Rib fractures are common. But what else?
Rib fractures alone aren't usually life-threatening, but you're looking for serious stuff.
Yeah.
Hemothorax, blood in the chest cavity, pneumothorax, air, collapsed lung, pulmonary contusion, bruised lung, flail chest, where a segment of ribs is broken in multiple places and moves paradoxically.
And tension pneumothorax.
That's a killer. Air trapped, squashing the heart and vessels. Needs immediate recognition and needle decompression, even before an x-ray. Less common, but very serious, are injuries to the heart itself or the aorta, the big artery.
Okay, abdomen, lots of organs in there. What gets injured often?
Spleen, liver, mesenteries, the tissues holding the intestines and their blood supply. They're hit frequently. Bleeding behind the abdominal cavity, retroperitoneal hemorrhage, is also fairly common, especially with pelvic fractures.
What about pancreas or bowel injuries?
Less frequent, but serious. They might not show dramatic signs immediately, but can lead to peritonitis, later inflammation from leakage. Also checking for kidney injury, blood in urine, flank pain.
And the pelvis. You mentioned massive blood loss potential.
Yes, pelvic fractures can bleed massively, especially posterior ones involving the sacroiliac joints. They can be hard to spot clinically, particularly in unconscious patients. A pelvic binder is often applied early to compress the pelvis and reduce bleeding.
Anterior fractures can cause other problems.
They're associated with bladder and urethral injuries. Need careful assessment for that.
Extremities, arms, and legs.
You can lose a significant amount of blood just from a femur fracture, a liter or more. Fractures are generally worse if they're open bone through skin comminuted, broken in many pieces, or badly displaced. And nerve or artery damage ramps up the severity.
What about just external signs, bruises, and scrapes?
Extensive bruising, especially from falls from height, can indicate significant underlying force and injury. Road rash burns and abrasions from sliding on pavement needs attention too. You have to examine the entire skin surface.
We talked about shock being a major red flag. Can we dig into the different types seen in trauma?
Definitely. Cold, pale skin basically means shock until proven otherwise. Remember, tachycardia, fast heart rate, isn't always there early, and hypotension, low BP is a late sign.
Yeah, the most common type is
Hypovolemic shock, loss of blood volume. Flat neck veins usually point to this.
where can all that blood be lost?
Externally, obviously. Into major fractures like the femur or pelvis, sometimes seen on x-ray. Into the chest cavity, hemothorax, detected clinically or by x-ray, confirmed when a chest tube drains blood. Into the abdominal cavity, hemoperitoneum, found with fast scan, DPL, CT, or during surgery. Or into the retroperitoneum, behind the abdomen, often seen on CT or inferred if other sources are excluded, especially with pelvic-lumbar spine fractures.
But other types of shock can happen too.
Yes. Cardiogenic shock, the heart pump failing. You might see distended neck veins. Causes. Could be tension pneumothorax compressing the heart, a heart attack happening concurrently, cardiac tamponade fluid squeezing the heart, or myocardial contusion, heart bruising from chest impact.
What about neurogenic shock?
That's from a high spinal cord injury, usually above T6, disrupts nerve signals controlling blood vessels. You get low blood pressure, but paradoxically, warm, flushed skin due to vasodilation, maybe slow heart rate, loss of anal tone, priapism. It's often a diagnosis of exclusion rule-out bleeding first.
And septic shock.
Less common immediately after injury. It's from severe infection. Could develop later if someone aspirates stomach contents and gets pneumonia, for instance. Not usually the primary concern right at the start.
Let's shift to imaging. How do teams see inside the body? What's the role of radiology early on?
Radiology is absolutely vital, but you have to be smart about using it early, especially if the patient is unstable. The source is stress, keeping unstable patients low consciousness, breathing issues, shock in the ED for initial x-rays where full resuscitation is available. Don't ship them off to a remote radiology department.
But also don't overdo it.
Exactly. Don't do endless x-rays on a shocked patient in the ED. Maybe limit it to, say, 3 key initial exams maximum to avoid delaying treatment.
What are those key early x-rays usually?
Chest x-ray is very common, usually done supine lying flat initially, and erect film gives more info for some things, but it's often impractical or unsafe. And remember, tension pneumothorax is clinical. Treat it, don't wait for the x-ray.
Cervical spine x-ray.
Used to be standard, but now, with fast CT scans widely available, CT is much better for clearing the neck in severely injured patients. So plain C-spine x-rays are less routine in the resuscitation bay itself, but the rule remains. Assume neck injury with head-face trauma or altered consciousness. Keep the collar on until cleared, usually by CT.
And pelvic x-ray.
Very important early on in unstable patients, especially if there's unexplained low blood pressure or suspicion of pelvic injury. It can reveal fractures causing major hidden bleeding or even a missed hip dislocation.
What about more advanced imaging like ultrasound and CT in that initial phase?
Ultrasound, specifically the fast scan focus assessment with sonography for trauma, is huge now. It's non-invasive, often available right at the bedside in the ED.
What does it look for?
Primarily free fluid, meaning blood in the belly, hemoperitoneum, or around the heart, hemopericardium. It's quick and helpful.
Any limitations?
Oh, yes. Its operator-dependent skill matters. Can have false negatives, misbleeding, or false positives. Not great for diagnosing specific organ injuries, bowel rupture, or bleeding stuck in the retroperitoneum or pelvis.
So its main role is?
Often in the unstable patient. A positive FAST showing fluid in the abdomen in the right clinical picture usually means straight to the operating room. No need for further imaging delays.
What about DPL diagnostic peritoneal lavage?
Less common now, largely replaced by FAST and CT. It's blood or bowel contents. Still might be used in some situations, but needs caution, especially in pregnancy, prior surgery, or with big pelvic injuries. Results are based on seeing gross blood or lab counts of cells and amylase in the lavage fluid.
And CT scans of the abdomen.
Increasingly the go-to for stable patients. Provides amazing detail of organs, bleeding, needs 5E and sometimes oral contrast. Requires experienced interpretation. Still has some blind spots, diaphragm, pancreas, some bowel injuries can be tricky, though free fluid without solid organ injury is suspicious.
Let's circle back to fluid resuscitation. What types of fluids are used and are there key considerations?
Okay, so while stopping the bleeding is priority number 1, hypertensive or vasoconstricted patients often need IV fluids and frequently early blood transfusion. The first fluid is usually an isotonic crystalloid normal saline or a balanced salt solution like Ringer's lactate.
Just to boost volume quickly.
Exactly, but for significant shock, early blood and blood products are crucial. The trend now is towards damage control resuscitation, giving packed red cells, plasma, and platelets early, often in a balanced ratio, like 1.1.1, mimicking whole blood.
What about practicalities? Getting fluids in fast.
Use large bags, maybe pressure bags or pumps. Warm the fluids of giving large volumes to prevent hypothermia, which messes up clotting. Rapid infusion devices can deliver huge amounts quickly.
Are there fluids to avoid? Colloids.
Yes, the sources highlight that colloids like albumin are generally not recommended in trauma, especially with traumatic brain injury. Studies like the SAFE study suggested worse outcomes, possibly higher mortality.
What about massive transfusion protocols, MTPs?
These can be life-saving in patients bleeding uncontrollably. The idea is aggressive, coordinated replacement of red cells, plasma, and platelets in those high ratios. It's been shown to improve survival. Hemostatic drugs like tranexamic acid, TXA, are often given early too to help stabilize clots. Other agents like prothrombin complex concentrates might be used for severe clotting problems.
I've heard of permissive hypotension. What's the idea there?
Right, permissive hypotension. This is mainly considered for penetrating trauma like torso stab or gunshot wounds. The thinking is, if you aggressively push fluids and raise blood pressure before the surgeon has fixed the bleeding vessel, you might pop off clots, worsen bleeding, and dilute clotting factors.
So you let the pressure stay a bit lower deliberately.
For a short time, yes. Aim for a systolic pressure around maybe 80-90 millimole Hg until surgical control is achieved. Limit crystalloids initially. Some studies show it helps early survival in penetrating torso trauma.
but not for everyone.
Absolutely not. Big cautions here. Probably not wise for blunt trauma, especially with any suspected traumatic brain injury, TBI. Hypotension is terrible for an injured brain. Also, probably not for patients far from a trauma center with long transport times.
How does TBI specifically affect fluid choices?
With TBI, avoiding hypotension is paramount to maintain brain perfusion. Under resuscitation is dangerous. Initial resuscitation with sodium-containing crystalloids is generally fine. Later, though, you want to avoid excessive sodium and definitely avoid too much free water, which could worsen brain swelling.
Okay, we've covered initial radiology. What about imaging after the primary survey and initial resuscitation? Are there other priorities?
Yes, once the patient is more stable, or at least initial resuscitation is well underway, further imaging is often needed. As we said, unstable patients ideally stay in the ED for x-rays.
What gets done typically after the initial phase?
A repeat chest x-ray is common, checking for changes, line positions. CT of the cervical spine is now the standard for definitively clearing the neck of injury, replacing plain x-rays in most major trauma cases. But remember, keep the collar on until it's cleared.
Pelvic X-ray, if not done already.
Yes, especially if stability is still an issue or a pelvic injury is suspected, to look for those fracture sources of bleeding.
What about skull X-rays or extremity X-rays?
Plain skull films, not very useful. CT brain is what you need for head injuries. Extremity x-rays, usually not urgent unless you suspect a vascular injury needing immediate attention, often done later or going straight to surgery for fixation.
Spine X-rays beyond the neck, abdomen X-rays.
Thoracic or lumbar spine x-rays, rarely needed urgently in the ED. Plain abdomen films. Limited value in blunt trauma may be helpful sometimes for tracking paths and penetrating injuries.
So CT really takes over for many areas.
For stable patients, yes. CT abdomen pelvis gives great detail. CT head is essential for TBI. CT neck is best for C-spine. CT chest can further define lung issues and is key for aortic injury diagnosis. Multi-site CT angiography is the standard now for that, replacing older methods like aortography.
Any other specialized imaging?
Urethrophy for suspected urethral injury before putting in a catheter. Cystography for bladder injury, CT isn't clear. And interventional radiology is important therapeutically, like embolization, using coils or substances via catheter to block bleeding vessels, especially in massive pelvic fracture bleeding. But getting an unstable patient to the IR suite is logistically tough.
Traumatic brain injury keeps coming up as critical. What are the key emergency management points for TBI within the context of multiple injuries?
Head injuries are common, yeah, even if urgent brain surgery isn't needed quite as often as you might think. TBI can be obvious or seem minor initially, but it hugely impacts outcome.
Initial treatment follows the ADCs.
Exactly. Airway, breathing, circulation first. If there are signs of brain herniation like pupils becoming fixed and dilated, rapid consciousness decline not due to low oxygen or shock, then mannitol, an osmotic diuretic, might be given IV.
To reduce brain pressure.
Yes, to relieve pressure on the brainstem. But crucially, only after ensuring the patient has enough fluid volume, because mannitol can worsen hypervolemia. Hypertonic saline is often preferred over mannitol in the ICU setting now for managing high intracranial pressure. The main goal is maintaining cerebral perfusion blood flow to the brain, which means strictly avoiding hypotension.
How is the neurological status assessed when other factors might confuse things?
It's tricky. Low oxygen, shock, alcohol, drugs, they all cloud the picture. Clinical evaluation relies on serial GCS checks and looking for lateralizing signs weakness on one side, for instance, suggesting a focal problem.
When is a CT scan definitely needed?
Anyone not obeying commands needs a CT, especially if sedated or paralyzed for other reasons. If someone's consciousness is dropping and they develop lateralizing signs, they need an immediate CT or maybe even emergency burr holes if CT isn't available instantly, though that's less common now.
What if they also have major abdominal bleeding?
That's a tough call, but generally, life-threatening abdominal hemorrhage takes priority. Laparotomy surgery to stop the bleeding often comes before the head CT if the patient is unstable from blood loss.
How do doctors actually score or measure the overall severity of all these injuries, and how is that used?
There are several scoring systems. A fundamental one is the Abbreviated Injury Scale, or AIS. It divides the body into 6 regions and scores specific injuries from 1 minor up to 6 unsurvivable, originally for car crashes, but used for all trauma now.
And Injury Severity Score, ISS.
That's derived from the AIS. You take the highest AIS score in the 3 most severely injured body regions, square each score, and add them up. gives a score from 0 to 75. Generally, 16 or more is major trauma. Mortality climbs steeply with higher ISS, especially over 25.
Are these scores the whole story?
Not really. They're mainly anatomical based on the injuries themselves. They don't fully capture everything influencing outcome. Age, pre-existing health, how physiologically disturbed the patient is on arrival, quality of care, complications.
So the physiological scores too?
Yes, like the Revised Trauma Score, RTS. That uses GCS, systolic blood pressure, and respiratory rate on admission. Then there's TRIS Trauma Score Injury Severity Score, which combines RTS, ISS, and age to predict survival probability. It's used for comparing outcomes between centers.
What about ICU scores like APASI?
Generally not ideal for the initial trauma assessment in the ED. Pre-existing illness, comorbidity, is a huge factor in how well someone recovers. And shock itself leads to major complications down the line: kidney failure, ARDS, lung failure, sepsis, liver failure, multiple organ dysfunction.
Kidney failure can be tricky to spot.
Acute kidney failure with low urine output isn't that common right away. More often you see non-oliguric kidney injury, later kidney function is poor, but urine output might be normal or even high, which can be misleading.
It's quite sobering to think about the actual numbers. What does the epidemiology, the study of injury patterns, tell us?
It is stark. Only a minority of people with truly severe injuries actually survive to reach hospital. Most deaths happen immediately at the scene.
And of those who get to hospital?
Some die early, in the ED or OR within hours. Fewer die later, in ICU or on the ward, often from severe head injury or multiple organ failure. It's also true that most trauma admissions overall aren't these severe multiple injury cases.
What are the most frequent life-threatening injuries?
Usually involve the head, abdomen, or chest, often in combination. And these severely injured patients consume a huge amount of resources: surgery, ICU, radiology, CT scans. Major outcome studies, like in the US, UK, Australasia, confirm this and often link mortality strongly to serious head injury.
It sounds like success hinges just as much on organization as on individual skill.
Absolutely. Many problems in trauma care are organizational: getting advanced care to scene quickly, rapid transport to the right hospital, clear hospital policies and triage, efficient evaluation and decision-making, safe inter-hospital transfers if needed.
So pre-hospital and hospital care need to work together seamlessly.
Critically important. That's led to the idea of regionalization, designating specific hospitals as trauma centers with strict requirements for staff experience, resources, patient volume. It involves ambulance bypass protocols, helicopter use.
And trauma teams within those centers.
Yes, having a dedicated team, surgeons, anesthetists, intensivists, nurses, ready to meet the patient immediately on arrival. Trauma registries and databases are also vital for tracking data, auditing care, and driving improvements. UK studies, for instance, highlighted issues like junior staff handling initial resuscitation or delays to surgery contributing to preventable deaths.
What about smaller, non-trauma center hospitals?
They face real challenges. Not enough volume to maintain expertise, lack of facilities. Transferring patients is ideal, but can be risky due to distance or transport limitations. It's tough.
And trauma remains a major killer, especially for younger people.
Yes, a leading cause of death and disability under 38 in many Western countries. Reducing that toll needs a multi-pronged approach: public education, legislation like seatbelt laws, better on-site care, rapid evacuation, hospital expertise, and coordinating all those services effectively.
This has been incredibly detailed, a real deep dive into this complex world.
Yeah.
If you had to summarize the absolute core principles for our listeners, what are the main takeaways?
Okay, I'd say successful management hinges on being swift, systematic, and prioritized. Start with that rapid CABC assessment for immediate life threats. Follow with prioritized interventions, support vitals, stop bleeding, then a thorough head-to-toe secondary survey.
And use fluids and imaging wisely.
Exactly. Judicious use, tailored to the patient. And underpinning everything is the crucial role of organized trauma systems, getting the right patient to the right place at the right time.
Any key aha moments from all this?
Maybe understanding why you might stop catastrophic bleeding before airway sometimes. The nuances of fluid resuscitation and permissive hypotension versus TBI needs. Knowing imaging is powerful but has limits in the acute phase. And maybe the biggest aha is realizing how much the system matters: pre-hospital care, transport, trauma centers. It all has to work together.
Absolutely. It's a remarkable combination of individual skill and system coordination.
Yeah.
Even without being a medic, understanding these principles gives you a real appreciation for the complexity. So here's a final thought to leave everyone with. Trauma care is always evolving, isn't it? Learning from conflicts, refining resuscitation, improving organization.
Constantly.
What ongoing challenges or future directions do you see? How might technology, data, or our understanding of the body's response change things even further? Something to definitely ponder. Thank you for joining us for this deep dive.